Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. In this video, we're going to talk about CVA, cerebral vascular accident, as well as spinal cord injuries. So CVA is also known as stroke or brain attack. This is a sudden loss of brain function resulting from disruption of blood supply to the involved part of the brain, causing either a temporary or permanent neurological defect. Okay? Some of the contributing factors about CVA include hypertension, obesity, aneurysm or cranial hemorrhage, peripheral vascular disease, diabetes mellitus, hyperlipidemia, as well as smoke or cocaine use. Signs and symptoms of a CVA would be the severity of the neurological defect is determined by the location and the extent of the tissue ischemia, which is tissue damage, and physical manifestation occur on the opposite side of the damage of the brain. This means that the extent of the damage depends on the part of the brain that is being involved. And if you have a right-sided stroke, it affects your left side, and as well as your left side will affect your right side. So some of the signs and symptoms of a CVA include changes in mental status. We'll have a slurred speech, aphasia, or as well as dysphagia. We're going to have either sudden severe headache. Visual changes will be noted. There will be cranial nerve disturbance, and the patient will experience numbness, weakness of the face or extremities, especially on one side of the body. Remember, key thing, left language, right reckless. Some interventions for a patient who has a CVA. So maintain that airway. ABC is always priority because if the patient is not breathing, nothing is more important. So we monitor neurological functions as well as the vital signs. We'll establish a baseline of the function and Glasgow Coma scale. Remember, if a patient has a CVA, they'll have a new baseline. So we need to get to know the new baseline. So when there's a change in the patient, we know there's a change. We'll maintain fluid and electrolyte balance. We'll monitor for aspiration due to the risk of dysphagia, and we'll feed the client slowly by placing the food at the back of the mouth and to the unaffected side. Remember, if you have a stroke, it affects one side of, you don't want one side of your body. So you could have facial, muscle weakness on one side. You don't want to put food on where the patient cannot chew, right? Don't choke. And then we'll provide psychological support for both the patient and the family. We'll also establish communication with the patient experiencing aphasia, right? Expressive, receptive, or global aphasia. We'll encourage the patient to be slow and deliberate in speech. Because remember, this is a new thing. It's going to be new to them. They were used to speaking okay. Now their speech is stuttered. They can't express themselves as well as they need. We need to let them know that we are there to listen to them and give them things that will help them express themselves. Give them a pen. Let them write. Give them a tablet. Let them type. Okay? We'll always perform range of motion, flexion, contractures to keep the extremities position extension or neutrally. Remember, they are losing function or they're getting paralysis on one side. We don't need contractures, right? We need to give the patient range of motion because you don't use it, you lose it. We're going to maintain skin integrity. If they are becoming incontinent after the CVA, we need to make sure they are dry. We need to help them, maintain skin integrity. We're going to monitor for Hemi Paralysis and hemiplegia, which can cause safety issues. You need to let the patient know. Let them scan the room, right? From the affected to the unaffected. Let them scan the room so they know where things are so they don't trip and hit themselves. We're going to help the patient as well achieve bowel and bladder control. Remember, we talked about paralysis. They may need bowel training again. And then we'll always place articles within the client's visual range, right? We need them to see the thing. So if they're having visual difficulties, you don't put it on the affected side. Put it where they can see it so they don't get frustrated. So treatment for CVA. With CVA, we'll treat the patient with thrombolytic therapy, and it's contraindicated if the patient has had the CVA for longer than 4.5 hours. We could have the surgical removal of the hemorrhagic CVA and endovascular intervention for embolytic or carotid artery angioplasty or placement of a stent. Education will always educate the patient that will refer them to all this therapy because it's going to be relearning this. So occupation therapy, speech therapy, speech pathologist for swallowing, right? Next, let's talk about the spinal cord injury. What is a spinal cord injury? It could be either a partial or complete disruption of nerve tracts and neurons, right? Remember, your spinal cord has nerves covering it. So it either could be partial or incomplete. It results in paralysis, sensory loss, altered activity, and autonomic nervous system dysfunction. Some of the causes of spinal cord injuries include sporting activities, violence, falls, motor vehicle crashes, as well as males of ages between 16 to 30 years are at high risk of spinal cord injuries. Types of spinal cord injuries include contusion, lacerations, compression of the cord, and complete transsectional, which is paralysis below the level of injury. So signs and symptoms. So cervical, partial or incomplete, quadriplegic or tetraplegic. Symptoms include, so the respiratory dysfunction, the client may be on a ventilator when you have a cervical injury of the spinal cord, right? Your respiratory function might be depleted. They might have partial or complete paralysis of all the four extremities, which is quadriplegic or tetraplegic, and they could have a loss of bowel and bowel control and alteration in sexual dysfunction. For thoracic injury, which could include partial or complete paraplegic, this will include a loss of bowel and bladder control as well as altered sexual function. We'll have the partial or complete paralysis of lower extremities and major control of body trunk. Because think about it, it's starting from your thorax. So going down, the more paralyzed you are, the less control of your body you have. And we'll have potential complication of autonomic dysreflexia. Autonomic dysreflexia, which is an injury below level T6, and respiratory complications. We'll talk more about autonomic dysreflexia and what to watch for and some nursing interventions on it. So with the lumbar spinal cord injury, either partial or complete paralysis of lower extremities will be noted, and there will be loss of bladder and bowel control as well as what? Altered sexual function. So treatment for this. Treatment for spinal cord injuries will immobilize the client, use a spinal board, halo traction or traction on a cervical collar. Immobilize the patient, right? The more you move the patient, the severe the injury will be. So make the patient be as still as possible. We'll maintain and monitor respiratory status, right? We'll monitor for spinal shock. And some of the signs and symptoms for spinal shock include loss of sensation. They'll say, I can't feel my fingers, I can't feel my toes, flaccid or paralysis and reflexes of below the injury level. So we'll monitor also for neurological shock, and some of the signs and symptoms of neurological shock include decreased blood pressure, heart rate, as well as cardiac output, and as well as venous pulling. So we'll have a decreased cardiac, it's neurogenic, we're decreasing, everything is decreasing. We will monitor for autonomic dysreflexia, which is a life-threatening syndrome with sudden severe hypertension triggered by the noxious stimuli below damage of the cord. And some of the causes of this could be autonomic dysreflexia. You will see this in the test. Always remember, autonomic dysreflexia is stimuli. Any irritation can cause automatic dysreflexia. This could include impaction. The patient did not have a bowel movement. Bladder distension. They could have a catheter in. It's not draining. It's kinked. They're not voiding. They could have pressure points, ulcer, pain. The sheet is not straight. There is something crinkly. You left a pen on the bed. Please be careful with patients with spinal cord injuries. And some of the signs and symptoms of this autonomic dysreflexia include hypertension with bradycardia, a very high heart rate. They'll have headache and flushing. They'll have goosebumps and sweating, as well as nasal congestion. So interventions for autonomic dysreflexia include, you will administer the medications as prescribed. Remember, the patient is having a high blood pressure. We need to bring the pressure down. We'll teach the client bowel and bladder management, right? So if the patient has not gone to the bathroom after 3 days, okay, they need to be aware that they should be asking for a laxative. Give them a suppository, give them something to help them move those bowels. Because if they have paralysis, the bowel motility could be decreased, right? With bladder management, if they can't pee because of the paralysis, they need to know after a couple of hours, 2 hours, or every 3 hours, they need to catheterize themselves to prevent bowel distension. Remember, they might be losing, they're paralyzed. They don't feel the distension. And determine and remove the causative stimuli. So if it's something in the bed, if they're impacted, if their bowel is full, we need to remove that stimuli to stop this autonomic dysreflexia. And lastly, we'll place the patient in a high phallus position to help decrease the blood pressure. Remember, you want the patient sitting up. You don't want a patient with high blood pressure laying down and increasing that pressure to go to in the brain. The blood pumping for going to the brain. Treatment is normally, there could be surgical management of whatever, will be triggering this dysreflexia. And with this patient, we normally refer them to therapies, right? Physical therapy, occupation therapy, Let them be aware, let them relearn their normal body systems. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.